everybody. We are having conversations about COVID today with Dr. Eric Bush, who's the Chief Medical Officer for Hospice of the Chesapeake and Chesapeake Supportive Care. And today we're talking about 5 things that you should consider if you or an older loved one is being hospitalized due to COVID-19. So Dr. Bush, first, thanks for taking some time out of your day to talk about this, because the hospitalization piece is pretty intense with the COVID-19.
Thanks. It is very intense, and the hospitals, the healthcare system is very stressed right now.
Right. So
one of those things to look at is if you were to be afflicted with COVID-19, or if your loved one, what are the implications of that for them, and where are they at in their current trajectory of life? Do they have any chronic illnesses? Do they have any progressive illnesses? Heaven forbid, do they have something like cancer? What does that mean in the context of what's going on in the current pandemic?
So I would think especially, let's focus today on a person who's older, because my understanding, and correct me if I'm wrong, someone who's older has a lot more risk with COVID-19 versus a younger person. So if a person who is older, if it's us, if it's our loved one, and they're going into the hospital, what's one of the very first things that should sort of happen if they're admitted to the hospital for COVID?
So the conversation with the medical provider that's making that diagnosis, as well as assessing not only the patient's age, but where they are age-wise from a functional perspective.
Okay.
I've been fortunate enough to care for some older folks that are highly functional. The oldest person I ever cared for was 108.
Oh.
And I can tell you that the way to look at it is, how are these people with their ADLs, or activities of daily living? How much are they able to get around? Do they need to utilize a rolling walker or things like that? If so, are they able to get around fairly independently, prepare their own meals, bathe and dress themselves? If they are, and functionally they're doing pretty well, then, I think sometimes that's a different conversation. You want to see how they're doing and responding to some of the interventions, versus if you have somebody who has an end-stage dementia or other progressive illness, and they do not have that degree of functionality. They're bedbound, and their loved one or caregiver needs to do all their activities of daily living for them. Then their likelihood of mortality from something like COVID-19 is likely much higher. And then you have to evaluate, is it worthwhile to look at something like intubation and mechanical ventilation? And when I say worthwhile, from a quality of life perspective, because if you have somebody like that, one of the questions should be is, if you intubate them, are they ever going to be able to get off the vent? And is that something that grandma, grandpa, mom, dad, aunt, uncle, that they would have wanted in the first place?
Right.
So those, to me, are the first conversations that should be happening.
Okay. So really just sort of the first thing would be understand where they're coming into, where they are starting out, like their baseline, where they're coming into to the hospitalization. And then maybe second would be really kind of projecting then, if you are doing some intervention, what that looks like, what the prognosis is for them.
Right.
Okay.
Medicine is like life. Everything comes down to risk versus benefit.
Yeah.
There is no free lunch per se. And whenever you do something, there's going to be some degree of burden, side effect, potential complications. And so those are the things that are weighed. And one of the conversations I have all the time, even prior to COVID, is this an acute reversible process versus a chronic and progressive and irreversible process? And if you have somebody who has a chronic or progressive irreversible process, and you have something like COVID superimposed on it that can be highly acute, then that's a different conversation than somebody who was, 40 years old, highly functional, ended up with COVID, and unfortunately now has a very difficult course, but maybe had some underlying high blood pressure and nothing else, so to speak.
Right.
Those are two different conversations to me.
I think sometimes the challenge becomes too, for definitely the older population, is sort of finding the right words and asking the right questions, right? You don't necessarily understand all the medical terminology that's being thrown at you. From a provider medical perspective, do you appreciate when people kind of say, okay, wait, that didn't make sense to me. Can you explain that in a different way? Is that something that you should encourage people should be open to do?
Yeah, absolutely. And folks, generally speaking, who are 80 plus, they tend to be, generally speaking, rather stoic in order to get to that age. They tend to minimize the things, the everyday aches and pains, the everyday shortness of breath, the everyday maybe some of the cognitive issues. They tend to minimize those in order to keep going. And that's a healthy thing. When you speak to them, one of the things I've come to appreciate is if you ask pain, almost always they will tell you no. But if you ask discomfort, especially when you see some of those nonverbal cues that indicate that somebody is uncomfortable, they will admit to discomfort, which to you and I often means pain.
Right.
Same thing with anxiety. Don't really use the word anxiety with those folks, but if you ask them if they're feeling nervous or restless inside, again, almost always they will tell you yes. They will indicate that is a challenge for them, because they will not admit to being anxious, because anxious has a whole different connotation to them than it does to you or I. You and I can talk about anxiety, and
Right.
whether it was the commute and the 5 cups of coffee we've had, the traffic and all that, we could talk
Right.
about anxiety.
Right.
But folks in that age group, so you do have to use terminology, you have to flex to their perspective, and you have to incorporate not only with the verbal part, what their nonverbal cues are, what the patient's nonverbal cues are, his or her, and are they concordant or discordant with the conversation.
Right.
And that's a whole other piece to it that I could talk about for hours.
Yeah, we
So,
could have, that's going to be a separate conversation. But I think it's important what you're saying. Like it's almost, we have to make sure that we're communicating the same way, right? That we're
correct.
understanding from both ends, from your end as a provider, what you're asking the patient, and from the patient's end to what the provider's saying, that clicks. Because, you as a medical provider use a lot of terms that the general public might not be aware of. Acute,
Right.
like what does that mean? Versus it's just, there's definitely a different medical speak versus what the common person understands. So I think it's on both ends. We need to sort of try and find a common ground of what we're talking about.
Absolutely.
So one of the things that, in our world, we talk a lot about are goals of care, and that's really important to have when you're understand and have when you're having a medical crisis or you're in the hospital. Can you touch on that a little bit? Like what does that mean when you're hearing providers talk about goals of care?
Sure. So goals of care are the things that you or your loved one would or wouldn't want done, and escalation and or de-escalation of care, and what the focus of your care should be. And so number one, what is your understanding of either your own medical issues or your loved one's medical issues, and what conversations have you had with your family, with other medical providers? What is your understanding of that? That's number one. And then number two, what you would or wouldn't want done about that. And again, what the reversibility of that is. So is it something like a urinary tract infection that's fairly simple with a bacteria that's easy to treat, that you have a choice of a half dozen antibiotics to give, oral or IV, versus maybe someone who has 7 or 8 medical comorbidities and now has their 4th urinary tract infection in the last 3 months, 2 hospitalizations, and now you're down to one IV antibiotic that you could give, but is going to have a lot of side effects, including things like seizures and renal failure. Again, you have the same diagnosis, a urinary tract infection, but with two very different presentations given the milieu or background.
I'm going to back up a second. Would that impact as well is if you're coming in with a COVID diagnosis, like say you have a history of that sort of bouncing in and out of the hospital, will that play a part in as well?
Correct. Having had multiple recent hospitalizations in general tells you that somebody's just not getting better, and the likelihood of this being something acute that's reversible is likely low. And
Okay.
this is probably more of a larger chronic progressive issue or multiple medical issues, whether it's heart failure, diabetes, COPD, pulmonary hypertension, plus some debility where somebody has lost their functionality, is having decline in nutritional status. When you put all those things together and look at the forest for trees, that's a different picture again versus somebody that has an isolated systolic hypertension and was otherwise highly functional and able to do everything they wanted to functionally.
Right. So it's sort of teasing through, again, going back to, okay, what's your history been prior to coming in? And then what matters to you, and kind of like aligning those two things.
Correct. Because the other piece that goes hand in hand with that is then having frank and open conversations with your healthcare providers about what those things mean.
Okay.
A lot of times in medicine, we tend to minimize the side effects. We make things seem smoother than they are when there's a chance of complications. For example, in hospital resuscitation, CPR in the hospital, the rate of successful resuscitation is only about 15%, 1.5, and that's in the hospital where you have all the bells and whistles and all the personnel that you need. And that percentage is unchanged over decades.
Wow.
And so those are things where it's not necessarily a technology thing. And yes, you'll hear about those miracle cases that happen at times, and those are great that those happen. But in general, something like CPR, where you're pressing on somebody's chest bone, if somebody has lost a lot of weight and they're significantly frail to the point that doing that is going to harm them, and unfortunately, I've had this happen, cases where I've been involved, that is not something you want to do, because that is only going to impact negatively on the patient's quality of life if they survive that, much less quantity, and the trauma that causes to the patient physically and for the family emotionally. That is, it is just the risk far outweighs the benefit.
Right. So really keeping in mind that risk benefit conversation.
Correct.
But I think the challenge sometimes becomes, especially for older individuals, that, you talk about some of the generalizations of being stoic and, hard to communicating differently. One of the other pieces that I think might fall into place too is that sort of respect and understanding for the medical profession, and sort of just not really questioning the medical provider, because thinking that maybe that medical provider knows or has a bigger insight into their care than reality. So I think that becomes a challenge too, that piece of not being concerned about asking or asking a question when it might seem offensive to the provider. Has that ever, if somebody asks you additional questions, does that offend you, or what's
No.
Okay.
No, I very much welcome additional questions. And you're right, folks in that age group, the geriatric age group, tend to have a lot of respect for medical professionals, and we appreciate that. And the benefit from getting opinion from medical professionals, we have our clinical experience to draw from. It tends to be more objective in nature. That being said, we are human, and we root for you. We root for you, and we say, hey, We've seen people that have been sicker, that have beaten it before, and most of the time that's true. And we want that to be the patient in front of us. That's what our heart tells us. It's just our heads don't always say that, and we have to balance that. And so I welcome very much when loved ones of the geriatric patient ask us questions, especially along the lines of risk versus benefit, because there's always options. And again, you just have to make sure that they align with what your goals of care are and where they align with the patient's trajectory in life too, as well.
Gotcha.
Yeah.
So final point that I think might be helpful for folks to understand during this time of COVID, if you do have an older adult, older loved one in the hospitalization, in the past, pre-COVID restrictions, you could pretty much have a loved one 24/7 in the hospital to be the eyes, ears, mouthpiece for their loved one. Unfortunately, with COVID-19 restrictions, that is not an option. Is there something you can suggest to loved ones to try and help, while you're not able to be in person, advocate for your loved one?
Yeah, this is something where, to me, you really need to try to leverage technology, and a lot of hospitals set up where they have, iPads with access or FaceTime, any way that you can see your loved one, because again, a picture really is worth 1,000 words. And if you're able to see them and how they're doing, it goes hand in hand with whatever written or verbal reports you're receiving from the treatment team, and can help you come to terms with where their loved one's illness is. And again, that's very complicated. Obviously with the patients that we see and in time of life that we serve people in, all bereavement is complicated at this time, and we appreciate just the degree of difficulty that this adds to trying to navigate a geriatric patient's illness currently. So again, utilize technology, utilize the treatment team, and speak to some of those ancillary components of the treatment team, the social worker, the chaplain, just to get a good perspective, not only the medical piece, but also the psychosocial, emotional, and spiritual piece, religious piece, how that patient truly is doing, to get a more 360-degree perspective.
Right, than just the clinical, which is just one
Correct.
part. Yeah, that's really
Right.
all right. All right, thank you so much. I appreciate you
Thanks.
sharing points on. I mean, it's a challenging time for anyone to be in the hospital, but especially if we have an older loved one that's in. All right, thanks, Dr. Bush.
Sure. Thanks, Tammy.
Yeah, I also want to thank the John and Kathy Belcher Institute for their generous support of the community education programs for Hospice of the Chesapeake.